Hello students. So let's take a look at the study guide for Exam 3. So the difference between bacteriostatic and bactericidal is bacteriostatic halts the reproduction of the dangerous bacteria. Bactericidal, suicide means death, kills the bacteria. So one just halts the replication of the bacteria, allowing the body's natural immune system to take over and clear the bacteria away. And bactericidal kills the bacteria. I want you to know which drugs are cidal and which ones are static. So let's see. So cephalexins, penicillins, those are cidal. The macrolides, which includes like the erythromycins, are static. There are a couple of others, but those are the ones I want you to know. The penicillins, the macrolides, which includes erythromycin, azithromycin, clarithromycin, and what else did I say? Oh, cephalexins. Okay, so antagonism, like antagonizing your sister or brother, you're at each other. They work against each other, and then synergy, like I think about yoga, you're in flow, you work together, and how it's related to bactericidal and bacteriostatic combinations. So you never combine a bactericidal agent such as penicillin and a bacteriostatic agent such as erythromycin together because the bacteriostatic agent will prevent the bacteria from getting to the stage at which the bactericidal agents work. So when you combine a cidal and a static agent, essentially you only have the static agent that works. So that's antagonism. If you combine two bacteriostatic agents together, so that would just have an additive effect, meaning 10 milligrams of this one and 10 milligrams of this one equals 20 milligrams of either one alone. It's just additive. And then synergism is when you combine two cidal drugs together. So if you combine penicillin and cephalexin together, it would be like 10 milligrams of this one and 10 milligrams of that one. It's almost the equivalent of giving 50 milligrams of either agent. They work really well together. You'd have something like that or need something like that when you are dying from an infection. Let's see, number 4, general drug interactions between anti-infective and other drugs. Decrease, increase effect of each drug. So when you combine anti-infectives and warfarin, you can get an increased warfarin effect, increase in bleeding. And the reason for that is twofold. One is that there are some anti-infectives that inhibit the liver enzymes. Slowing down those enzymes means that the warfarin is not getting metabolized as fast, leading to more building up in the blood. Additionally, we need the bacteria in our guts to create vitamin K, which is part of the platelet factors. So there's 2 reasons why you end up bleeding more when you take antibiotics with warfarin. Antibiotics, so that's an increase in warfarin's effects, increased bleeding. Second one is oral contraceptives. Decrease oral contraceptives effects, so the person needs a secondary form of birth control. And then, of course, the other ones, when you combine a cidal and a static together, decrease the effect of the cidal agent, making it absolutely useless. And then combining 2 cidals together increases or creates synergy, increasing the effects of each agent. See here. So know the antibiotic regimen for antibiotic prophylaxis. I'm not going to give that to you. You can look that up. The 2 grams amoxicillin. Most common antibiotic for dental infection. Oh, for number 5, you also have to know the one with the penicillin allergy, right? What is it? Clarithromycin. There's a cephalexin in there. So no, let's see, for those, know the clarithromycin one and know that 10% of the time, if someone has an anaphylaxis to penicillin or amoxicillin, they're allergic to all the cillins. 10% of the time, they will have a cross sensitivity to cephalexins because cephalexins are chemically similar in structure to penicillin. It's basically like an expensive penicillin. That's what cephalexins are. Most common antibiotic for dental infection is penicillin. The most common adverse effect of erythromycin is stomach upset. Ugh, rots the gut. Dental adverse effect of tetracycline, that brown staining of the teeth. Clindamycin, devastating adverse effect. That would be pseudomembranous colitis caused by usually an overgrowth of C. diff, which is Clostridium difficile. Bloody diarrhea. Which drug is associated with ototoxicity? So this drug can make you deaf and also hurt your kidneys. So ototoxicity and nephrotoxicity. And that drug is, what is it? The aminoglycosides. The anti-infective group with the highest allergenicity is penicillins. Sorry, I'm sipping tea here. Identify the route that sensitizes. So it's a topical. They used to have penicillin that you could rub topically on the skin, but it sensitized patients to becoming allergic in pretty significant allergies. So they don't have topical penicillin anymore. So that's the route that sensitizes, almost similar to like how latex gloves, wearing them on our hands for a long period of time. A lot of people became real sensitive to latex. So the topical route sensitizes people to developing allergies, and the route with the most serious reaction would be intravenous. So, you may have been sensitized to penicillin, had no idea, get an IV infusion of penicillin, and you're going to have a pretty serious anaphylactic reaction to that. And it's difficult because we can't retrieve it very easily once it's in your system. I already answered this one. So if you're allergic to penicillin, 10% of the time you will be related to the cephalexins. And you could almost always, just like how you could always identify when Tylenol or acetaminophen is in something because it has that CET, cephalexins have either CEF or CEPH in their name, like Ceftin, Ceflex. It's all different ones, but Cef is usually somewhere in the name. All right, 4 drugs that are used concurrently for active TB. So let me think. INH, PZA, ethambutol, INH, PZA, ethambutol. It's not streptomycin, rifampin. All right, so INH, PZA, rifampin, which gives you like that vampire look, and ethambutol. There's a 5th one that they've added recently, streptomycin. All right, but you just know the 4 and the 1 drug. If someone is infected, doesn't mean infectious. They have a latent infection, not active disease. Infected with TB is INH, that isoniazid, INH. All right, drug of choice for oral fungal infection seen in dentistry. So oral fungal infection seen in dentistry is thrush, right? It looks like you have cottage cheese in your mouth. You wipe it away and there's a red bleeding area. Drawback and advantage to the preferred delivery system. So it's those pastilles, which is kind of like little lifesavers that people stick on their buccal mucosa about 4 times a day. So patient compliance is the advantage. Patients don't mind sticking something on their buccal mucosa, going about their day. The disadvantage is it is like a lifesaver and that they are loaded with sugar. Suffix for most antifungals is azole. Now don't confuse it with prazole, right? Which is something for GERD. It's just azole, A-Z-O-L-E. Drug of choice for an immunocompromised patient with oral hepatic lesion, acyclovir. Doesn't work if someone has an intact immune system for an oral hepatic lesion. So is this drug indicated for a patient with an intact immune system? Only for genital herpes. It's not indicated if you have an intact immune system for an oral herpetic lesion. So what is HAART? HAART is highly active antiretroviral therapy, and it's a combination of antiviral drugs used in the treatment of HIV infection. How many combination of drugs? Sometimes 3, 4, 5 drugs now are used, but they have these great pills now. There's like one pill that contains like 3 of the drugs. So it's about like, let me see, we have non-nucleoside, nucleoside, protease, fusion inhibitors, entry inhibitors. So it's probably about 5 drugs now. So the drug groups, so that would be the non-nucleosides, the ones I just mentioned, fusion, entry, protease inhibitors, and then they're called nukes and non-nukes. And recognize that VIR is an antiviral. You don't need to know like, AZT, all the different antivirals for HIV. There's so many of them, it would be almost impossible to know them all. So I just want you to know like the groups, protease inhibitors. And so protease inhibitors are probably the drugs that are the most important in HAART. You don't really have to know that, but those are the drugs that are really extending people's lives for a long time and have really changed the course of HIV infection from a life-threatening, life-ending disease to a chronic condition, for your own knowledge. That. Oral side effects associated with antivirals, all right? So those are, because everyone kept putting down the conditions like NUP, NUG, that's oral path. You can learn that stuff in oral path. I just had a slide on that. What I'm talking about is the paresthesia, the dysgeusia, that weird taste, like a tingling from the paresthesia, probably xerostomia. So there's some kind of like funky oral side effects associated with the antivirals. General anesthetics, chapter 10. All right, anesthesia, nitrous. They should remain in stage 1. Signs and symptoms of appropriate sedation. So the two biggest ones, someone is appropriately sedated when they can respond to your commands, turn this way, turn that way, open your mouth, and their feet have tipped out to the side. When someone is relaxed, especially in a dental chair and they're on their back, when their feet tip out, that usually means they are relaxed, okay? So feet out, appropriate response to commands. Oversedation is when you enter 2. So think of 2 and 4 with sedation as bad. 2 is you go from being all nice and sedate to all cuckoo crazy, throwing up, peeing. We don't want any of that stuff, right? So if you start to see someone becoming agitated, right, you may be giving them too much nitrous. So that's stage 2. So what's the purpose of balanced anesthesia? So you don't want to just give someone 100 milligrams of this to make them unconscious, right? It doesn't work. You want to give them tiny bits of a whole bunch of different medications. It prevents side effects from happening when you can give lower doses, right? So they'll give you something to relax you, maybe an Ativan. They'll give you something to dry you up, but that will also make you a little sleepy. They give you, so there's a lot of different things to help get you in that sort of relaxed state to get you unconscious, right? So we want to think of lowering the dose, decreasing side effects is really the purpose of balanced anesthesia. So some of the pre-anesthetic drugs that may be used, there's a whole bunch, right? They might give you an anti-infective to prevent an infection. They may give you an anticholinergic to dry you up so they can intubate you. And also to prevent, vagal blockade. So vagus nerve, stimulating the vagus nerve, increasing the heart, blocking that decreases the heart, prevents vagal blockade. Okay. What are some of the other ones? They might give you succinylcholine to help to paralyze your muscles. So there's a whole bunch they may give you. And there's a slide on that about the pre-anesthetic drugs. So I would be familiar with those pre-anesthetic drugs that they may give you during induction. What happens if a person is stage 4? They could die. So 2, 4 bad, 1, 3 good, 1 relaxed, 3 unconscious, 2 being all fighty and cryy and disgusting, and 4 is death. So bad. 2, 4 bad, 1, 3 good. Most surgeries performed in stage 3. Most popular inhalation anesthetic used in dentistry, nitrous oxide, N2O. It may be used in someone with a history of malignant hypothermia. Oops, I gotta scroll down. Okay. Why would you combine nitrous with another inhalation anesthetic during surgery? Well, because most inhalation anesthetics that they use in surgery, like the rains, like the fluorines and all those other rains, right? They're pretty potent agents. And when you combine them with nitrous, you can actually lower the dose of the more potent agent, resulting in fewer side effects. That's why. Indications and contraindications and benefits to nitrous, right? Oh, benefits, relaxed dental team, kind of come up with those on your own. Contraindications, a patient potentially with mental illness, someone with COPD, someone that doesn't want it. Indications, fearful, anxious patient, right? So there's a slide on that. Nitrous oxide tanks are blue, oxygen tanks are green. Just like local anesthetic cartridges have certain colors, those are universal. Oxygen tanks are green, always. Nitrous is blue. You never want to mix them up. So what's a scavenger system? So when you put on nitrous, the nasal hood, it's called. It's like a little hat that sort of fits over your nose, and there are tubes that come out on either side of your cheek, extend backwards. A scavenger system is located inside the little nose hat, which is formerly known as the hood. And inside, on each side, are 2 tubes. So inside the hood is 4 tubes total, 2 on each side. 2 of the tubes, 1 on each side, are delivering gas. 2 of the tubes on each side are suctioning gas. So it's suctioning the gas that the patient might be exhaling or is coming out from the nasal hood to prevent the operators from being exposed to too much nitrous. Which gas is always used in conjunction with nitrous? Oxygen. What's tidal volume? So that has to do with the amount of oxygen or the amount of breath or air that we bring in and out in one inhalation exhalation cycle. So when you begin to add nitrous, why do you lessen the oxygen? Well, hint, keep the tidal volume the same, right? So when you put so for most human beings, your tidal volume will range anywhere from 5 to 10 liters. I think it's a minute. I think it's a minute. Anyway, it doesn't matter, right? And with most people being between 7 and 8. You really can't look at the size of someone. Like you might look at oh, that guy, I don't know, Peter Ganji. He's got a huge tidal volume, right? And this young, really tiny person, they have a small tidal volume. Probably not always, because the big person could have had lung cancer or smoked 10 packs. You can't smoke 10 packs a day, 2 packs a day, right? So you have to put the hood on and adjust it. So you'd probably start off at about 7 liters, delivering pure oxygen, right? Pure oxygen only, you don't even start the nitrous. So you give them the 7 liters and you say, can you feel the air? If they say no, then you might up it. If they say yes, it feels like it's blowing up my nose, then you decrease it. But you want to keep it the same, so then you'll start adding the nitrous in small increments. So you'll add a liter of nitrous, but that has increased how much air you're delivering through, the nitrous an oxygen tank. So then you decrease the oxygen by the amount of nitrous that you've added to keep the tidal volume the same. And then, really important, your patients won't like you if you don't do this. At the end of procedures that the patient has nitrous, you have to give them like a really good oxygen flush, meaning just straight up 100% oxygen, the nitrous is off, or else they get a wicked headache. And oh, it's an awful headache. So you have to give them a minimum 5-minute oxygen flush. Recommended concentration of N2O, 2 usually, especially for us, 35% nitrous, 65% oxygen. Highest recommendation, 50-50, 50% nitrous, 50% oxygen. Maximum is 65% nitrous and 35% oxygen. If you are at that level, you have a danger of the patient entering stage 2. All right. And that's messy and unpleasant. IV general anesthetic used in children. Ketamine. What is the major disadvantage to IV opioid administration? Respiratory depression. Most commonly used IV general anesthetic. It's called propofol. So you may have heard of propofol in the news. It's what killed Michael Jackson. And it looks like milk. It's white. So if you're ever going to have surgery and you see it, it looks like milk. And they call it, just like you've heard of milk of magnesia, they call propofol milk of amnesia. So that's it, propofol. Chronic exposure to nitrous can result in 2 side effects: spontaneous abortion, otherwise known as miscarriages, in males that impregnate females that work with nitrous and females that work with nitrous, and peripheral neuropathy, so tingling in the periphery. Oh, we're about halfway done. Oh, let me look here. How many more questions do we have? All right. Keep going. Keep keep positive. At rest, nerves are polarized at minus 70 millivolts. It's a net negative, right? So when they're resting, no messages, they're at a minus 70. Where on the nerve do local anesthetics work? They work in, right, I'm going to go from small to big. They work on the calcium receptor site within the sodium channel within the node of Ranvier. Saltatory conduction is messages hopping. It's a message hopping from node to node, unmyelinated section to unmyelinated section. It speeds up how messages are delivered to the brain and exit the brain. So if you know someone that has multiple sclerosis, these unmyelinated nodes have become sclerosed, hardened. So now the message has to travel the whole length of the nerve versus hopping, and that makes it much slower. And that makes their movements much slower. So sometimes you see someone with MS having a difficult time walking. So that's why. How many nodes need to be blocked in approximate distance? Okay, so you need to block about 2 to 3 nodes. And the approximate distance is about 10 millimeters for local anesthetic to work. If you only block 1 node, the problem is that sometimes if it's powerful enough, it can jump over, the message can jump over that 1 node to the next node, and the message of pain gets delivered to the brain. How do local anesthetics work? Local anesthetics block the influx coming inside, block the influx of sodium. Sodium doesn't come in, the message doesn't go to the brain. Which ions do they displace in the sodium channel? Calcium. If the pKa of a drug, and remember pKa has to do with the drug, pKa is the pH at which 50% of the drug will be ionized and 50% will be unionized. So when you take this specific drug with a specific pKa and put it in, I don't know, let's say the stomach acid, right? And it's acetylsalicylic acid, aspirin. pKa is very close to the acidic stomach. So you drop that pKa of aspirin, which is, I don't know, 2.5, into the acidic environment. So pKa has to do with the drug and the solution in which it's placed, that pH, and that will determine how much of the drug dissolved is ionized and how much is non-ionized. So if the pKa of the drug is 7.4 and the site of administration is 7.4, 50% will be ionized and 50% will be unionized. Is it the ionized cation or the unionized free base that plays a role in the person achieving anesthesia? Both. So it's the unionized free base. Let me go here, the skinny one, remember? So the skinny one can slide on through the nerve sheath inside the nerve. So this RN and RNH plus, you've just injected a whole bunch of lidocaine into someone, and this is what the lidocaine molecules look like, all right? They become RN and RNH plus outside the nerve. So this skinny free base slips inside, and then it becomes RN and RNH plus inside the nerve, and it's the RNH plus, the chubby one, that's big enough to go back up into the sodium channel. It displaces calcium from its receptor, it sits on it, and it's so big, right? Just think of sodium out here floating. Here comes the message of pain, but we've stopped it because the sodium can't come in because the RNH plus is sitting right here in the sodium channel. It doesn't say sodium channel here, but that's what's right here. Okay? So for a rebase, the RN slides in, RNH plus, two things. Kicks the calcium off the receptor, sits there and blocks the sodium from coming in. So in the diagram, you have to be able to tell me how many molecules penetrate the nerve, how many block the sodium channel, and why there is a difference when the pH changes extracellularly. So remember, infections, abscesses don't occur inside nerves. They occur outside nerves. So extracellularly means outside the nerve. And you can see here, I go back here, when the pH is 6, we only get 10 free base going in. Oh no! All right, we only end up with 7.5 molecules compared to here, which is 180 when you're healthy. So 7.5 molecules, that's nothing. That person's not getting numb. They're going to be screaming, ah, you're killing me. All right. So when the local anesthetic has a lower pKa, 7.7 versus 8.1. So they all have different pKas, different anesthetics, mepivacaine, lidocaine, bupivacaine, prilocaine. The closer the pKa is to the physiologic pH. So our physiologic pH is about 7.3. The closer it is, it means more free base molecules are formed, which indicates a more rapid onset of action. Doesn't mean that the drug is bad if they have a pK of 8.1. They just have fewer free base, takes a little bit longer to get numb, but that particular drug you stay numb for a long time. But lower pKa equals more free base, more rapid. I gotta move this down. Wait a minute. Okay. Two routes, parenteral, sub-Q, and topical. Where are amides metabolized? The liver. Esters are in the blood. Methemoglobinemia is linked to both amides and esters. The amide is prilocaine. The ester is benzocaine. It's topical. Atypical pseudocholinesterase. Hey, look, there's ester right in the word. Is linked to esters because pseudocholinesterase is the enzyme in the blood plasma that breaks down esters. In addition to being a peripheral nerve blocker, which two conditions may lidocaine be used for? So that will be, let's see, cardiac arrhythmias, because they also block the sodium channels in the heart, and additionally as anti-seizure medication. For most local anesthetics, central nervous system stimulation comes first for most, except for lidocaine. It depresses first, that's why it can be used as an anti-seizure medication. Now, when someone shows up to the hospital and they have an arrhythmia or they're having a seizure, they're not getting a dental injection of lidocaine like you see given in the clinic. They're getting an IV infusion of it at a much stronger dose, okay? So know that. So if someone's allergic to local anesthesia, they're usually allergic to an amide or an ester metabolite, usually an ester metabolite. And what ingredient may be added to the cartridge that a person may be allergic to? So the ingredient that a person may be allergic to is the, I lost my word, preservative for the vasoconstrictor, and that is sodium bisulfite. Now, this is important for you to know. People that are steroid dependent, we talked a little bit about that the last class, steroid dependent asthmatics. Every day they're taking a steroid to control their asthma for reasons not well understood. These patients tend to have very strong reactions to sodium bisulfite. So steroid dependent asthmatics should not have vasoconstrictor because of that potential for cross-allergenicity with sodium bisulfites. And so what would you do? You'd have to give them plain, mepivacaine plain. So which class of LA drugs is used parenterally? An amide. So when you're given a generic name of an LA drug, how can you determine if it's an amide or an ester? Well, an amide has two I's in the name, and an ester only has one. Mepivacaine can be effective without a vasoconstrictor because it's not super vasodilating. Most, like lidocaine, it's real vasodilating, but mepivacaine is not. Ingredients in the eutectic mixture of local anesthetics and Orachix is 2.5% prilocaine, 2.5% lidocaine. Getting there. Prilocaine is a relative contraindication for persons with certain conditions and taking certain medications. Okay, so prilocaine, if they have any kind of oxygen exchange disorder like hypoxic disorder, if they've had a past history of methemoglobinemia, and if they're taking large quantities of Tylenol. For some reason, acetaminophen Tylenol in conjunction with prilocaine can bring on a methemoglobinemia response. Paresthesia. Paresthesia is like a continued sense of numbness. It's usually tingling that people have. The local anesthetic that's associated with it is articaine, and that drug articaine is metabolized both. It has like a little kind of ester component to it, so it's metabolized in both the blood plasma and in the liver. Generic name of the first injectable local anesthetic is Procaine. Local anesthetics are usually vasodilators. That's why vasoconstrictors are added to the solution. The purpose of the vasoconstrictor is to keep the local anesthetic drug at the site of injection. That reduces systemic toxicity. It allows the person to become more numb, increasing the depth and the duration of the anesthesia. They do not help penetrate the nerve or anything like that. They just collapse down vessels. Vasoconstrictors just collapse down vessels around where you've deposited the local anesthetic drug like the lidocaine. Do all LA cartridges have them? No. What are the two kinds of vasoconstrictors, epinephrine and levonorepinephrine? Are they safe in cardiac patients and at what dose? So let's just know epinephrine. And they're reasonably safe in a cardiac patient. So that dose would be 0.04 milligrams is the amount of cardiac patient, which usually works out to be 2 cartridges of epinephrine at the ratio of 1 to 100,000. So vasoconstrictors are sympathomimetics, right? They make that heart rate increase. Patients will say, oh, my heart rate really sped up. And I usually just say, oh, that's normal. That's part of it. It will relax soon. Just speak in a calm, reassuring tone. So using the mnemonic, most locals produce anesthesia beautifully. Rank the anesthetics from shortest to longest acting. So that would be what? Mepivacaine, lidocaine, prilocaine, articaine, bupivacaine. Do topical anesthetics contain a vasoconstrictor? No. Should you use them on abraded tissue? No, because they'll get sucked into the systemic circulation. Which topical is preferred for large amounts of abraded tissue? 5% lidocaine base. Which topical should a patient not receive if they're allergic to esters? That would be benzocaine. Ooh, we will be doing math on this exam. So I'll provide you with the absolute MRD and the weight-based MRD. So let's see, determine. So I'm going to write on the board a couple of things. So I'm going to say, first, get the percent. And this is for the LA drug. First, get the percent, just like we did in class. So it's 2%, so we know 2% means 20 milligrams per 1 milliliter of water. 4% is 4 milligrams over 1 milliliter of water. So 40, sorry. So first get the percent and make that into 4% means 40 milligrams, whatever the drug is, over 1 milliliter of water. Let's see, first, second. How much is the cartridge? How much is cartridge? Third, how many cartridges? So I'm going to write that on the board. Whoops, spelling. Lots of them. I always spell cartridges wrong. Okay. So that will be on the board. First, get the percent. So once you get the percent, you have to know that what that means. How much is the cartridge times by how much the cartridge is. Third, how many cartridges. So check your work. And now for epi. So it all will be 1 to 100,000. So first, get the equation. So it's, what is it? 0.01 milligrams of epi over 1 milliliter of water. So you have to know that first. I'm going to say know the ratio. Know the ratio. Then second, how much is the cartridge? And third, how many cartridges? Okay, now determine the number of cartridges that may be administered safely. So what's the first thing you're going to do is you're going to figure out the weight-based first. Weight first. So I'll have this on the board. First, you have to determine, so you need a calculator. First, weight-based MRD. then compare to absolute. I'm not going to write this on the board. You're going to have to figure it out. Right? Choose the lowest. I'm not going to put that. Then first weight base, figure out weight base compared to absolute. Then divide by milligrams per cartridge.